So I'm not going to talk about hepatic encephalopathy. I'm going to talk about what you might even think of a differential diagnosis to hepatic encephalopathy. But there are a number of parallels, certainly to what we've heard about this morning, which I think is interesting. These are my disclosures. So the story goes back to the 20th century with this finding that patients with hepatitis C report many more impairments in quality of life compared to controls, compared to patients with other liver diseases, hepatitis B, which is not affected by the presence or absence of cirrhosis. And it's very clear that patients with hepatitis C have a very high prevalence of a great breadth of psychiatric comorbidity. So we all know there's increased alcohol abuse, we all know there's increased drug use, but fatigue and depression, anxiety are especially prevalent. And fatigue is something we know has responded and does respond to effective antiviral therapy, and these are large studies of interferon-based therapy, very simple assessment, just a visual analytic score, and patients who have a sustained virological response and know they've had a sustained virological response do feel better. I think this slide will summarize a lot of work by a lot of different people, and I'm not going to go through all the studies, just to tell you that cognitive impairments do occur at an early stage of hepatitis C infection in the absence of advanced liver disease. We see deficits in working memory and attention. They are not wholly explained by substance misuse, depression, liver disease severity, viral genotype, seem to be a cofactor in HIV infection. Co-infection, patients do worse than mono-infection. Some recent data from Karen Weissenborn working with Ruth Izaki have shown data which suggests that the ApoE4 allele may protect against these deficits, so a host phenomenon. But I think most importantly, especially when we're talking about why we treat hepatitis C, is that these impairments are related to health-related quality of life and fatigue. And this is a subsequent study that we've done really to demonstrate that not everybody with hepatitis C is symptomatic. They don't all complain of this sort of brain fog and an inability to function. And it's those who are symptomatic where we see impairments of attention and memory. And the order, the impact of this is equivalent to around 20 years of normal aging or taking a diazepam tablet. So is this biological or is this psychological? And the evidence for a biological etiology comes from work done with Simon Taylor Robinson using proton magnetic resonance spectroscopy, where we showed that in patients with mild liver disease without cirrhosis, there was an elevation in choline in the basal ganglion white matter, which was not seen in normal controls in patients with hepatitis B. This is not due to hepatic encephalopathy, and those changes are not typical of hepatic encephalopathy where a reduction in choline is seen. And there have been a number of other studies now using the same technique but different methodologies, which have showed essentially similar findings, elevations in choline, myonostal, and changes in N-acetyl aspartate. Now these features are suggestive of gliosis or neuroinflammation. What we haven't seen is a very consistent relationship between these metabolic changes and cognitive function. And there's a question there raised by Karen's group as to whether this actually represents the direct effect of the viral infection or some compensatory changes in the brain. So we have a type of brain syndrome associated with hepatitis C characterized by fatigue, cognitive impairments, which are generally mild, and depression. Is this due to direct infection of the brain, or is it due to an effect of the peripheral immune response, or a combination of both perhaps? And there are good studies now which do show that the virus does get into the brain, and the studies are suggestive of viral replication with the demonstration of negative strand RNA, which is a viral replicative intermediate, and also detection of brain as quasi-species. And you can see that there are motifs in the 5' non-structural region of the virus, which seem to occur frequently across different studies. Which cell? This is data from Laskus, who's done a lot of work here. They were able to get access to quite a good number of post-mortem brain samples from patients with hepatitis C, and laser capture microdissected different cells which were marked as here. And you can see here at the markers for microglial cell and astrocytes that they were able to isolate hepatitis C positive and negative strand in the cells thought to be microglia more consistently than astrocytes. And this is reflected in the staining, so co-localization of CD68 and a viral non-structural protein more than for the astrocytic marker. So there is evidence that the virus enters the brain. Does this account for the psychiatric symptoms through neuroinflammation? And we've already had reference a couple of times to the PET study done in Simon's group at Imperial. And yesterday we heard of the renaming of this receptor translocator protein, which when microglia are activated are expressed more, and this can be measured with ligands to the peripheral benzodiazepine receptor using PET technology. So what Simon and his group showed was that in a number of patients, again with mild hepatitis C without cirrhosis, there was increased binding. You can see in the thalamic area in this patient here. And I haven't got time to show you the studies, but with those microdissection experiments, there was upregulation of pro-inflammatory cytokines in those dissected microglial cells as well. What about the astrocyte? There's not very much literature on the astrocyte and hepatitis C, but this study from the States using primary human astrocytes attempted to try and infect and see whether the astrocyte would harbour a replication of the virus, and this was not the case. They are not infectable. However, hepatitis C viral exposure, just the virus, stimulated IL-18 expression and none of the other pro-inflammatory cytokines that you might expect, equivalent to what is also seen in this model with gamma interferon. And astrocytes express toll-like receptors, apparently particularly enriched with toll-like receptor 3. So just the presence of the virus in the brain, if it can come across the blood-brain barrier, may be sufficient to induce production of pro-inflammatory cytokines. This one, receptors are expressed on microglia and neurons. The cell which does allow hepatitis C replication is the brain microvascular endothelial cell, and this is a very interesting work from Jay McKeating's group in Birmingham, published a couple of years ago, which first demonstrated that these cells express all the receptors required for hepatitis C entry. But also, these cells in culture allow replication of the virus, shown here in these blocks, with RNA and protein, albeit at a lower level than seen in the Hu7 cell line in hepatocytes. What they also showed was that viral infection of the brain endothelial cells induced apoptosis, and before that, conformational changes which may allow leakage at the blood-brain barrier. So this led to the hypothesis that hepatitis C may infect some brain endothelial cells, resulting in a leaky blood-brain barrier, which would then allow free virus, cytokines, and potentially virally infected monocytes access to the CNS across the blood-brain barrier. So that's the virus. But what about cytokines? What about inflammation? And what are the lessons we've learned from interferon alpha? Well, interferon is the experiment, isn't it? It's an exogenous cytokine that we give at a very supraphysiological dose to patients with hepatitis C. It actually makes it very difficult to work out whether treatment has a positive effect on the brains of these people. But we do know that there are a number of mechanisms. and one of which is that interferon induces this enzyme, indoleamine 2,3-dioxygenase, which switches the metabolism of tryptophan away from serotonin down the kynurenine pathway. And you can look at the induction of this by measuring these two compounds and looking at the ratio. And this is the standard explanation for interferon-induced depression. Depression occurs during interferon, is paralleled by increased IDO activity. But there are other pathways, and this is reviewed very nicely in this paper this year. So we know that interferon induces IDO, and there may be serotonin depletion within the CNS, but the rate-limiting pathway is this, and when we have more kynurenines, they pass quickly into the CNS and are subsequently metabolized by two enzymes to quinurinic acid or quinolinic acid. And interferon tends to favor this pathway with more quinolinic acid, which it leads to increased glutaminergic activity and perhaps excitotoxicity. Interferon also, through this mechanism, induces the serotonin transporter with reduced serotonin activity, and also is thought to induce GCH1, which promotes the accumulation of dihydroneopterin. Neopterin is a byproduct which we can measure in the blood at the expense of tetrahydrobiopterin, which is important in serotonin and dopamine biosynthesis. So interferon works in all these ways, and the question is whether endogenous interferon, endogenous cytokines, may also have an impact. Well, we can measure neopterin, we can measure some of these compounds, and we can look at neurotransmitter activity with SPECT, and I come back to another paper by Karen, and I haven't got the data here, but she's shown that there are abnormalities in patients with mild hepatitis C using SPECT in dopaminergic and serotonergic neurotransmission. We looked at the kin-trip ratio in patients with mild hepatitis C, not on interferon, and showed that in fatigue patients there was a significant elevation, suggesting that there is IDO activity, increased activity, likely related to endogenous interferons, and this correlated well with neopterin and beta-2 microglobulin, markers of cellular immune activation. Another paper looking at immune factors published this year in patients with hepatitis C used Luminex technology. We've heard that Mark's done this as well in his model, and did a multi-analyte profile for 47 inflammatory factors in these patients. And patients with hepatitis C do demonstrate significantly higher plasma levels of 19 of these factors. Now this is very different in terms of the degree of activity to sepsis on an ITU, which we've heard about this morning, but there is chronic immune activation with increased levels of these factors circulating in these patients with chronic liver infection. And what they showed was that there was a significant correlation between just depression, anxiety and pain and the number of these immune factors that were elevated. And this is clearly, 5 more minutes, interesting to organic psychiatrists, particularly because they looked at protein signatures in this study and seemed to show that there was a clustering of some of these patterns of immune factors with various different neurocognitive impairments. So we have a clinical syndrome. The mechanisms may include infection of the blood-brain barrier, disruption of the blood-brain barrier, viral penetration, cytokine-mediated neurotransmitter, and other metabolite changes. The key question which has already been asked is, what about antiviral therapy? Now, I've already alluded to the fact that with interferon, the picture is very difficult, and we know that while patients are on treatment, they get depressed, they get worsened cognitive function, which tends to normalize at the end or just after the end of therapy. But if you look a year or more after effective antiviral therapy, and this work has been done now, the effect of a virological cure on cognitive function seems to be positive. In quite a large study, patients who had a sustained virological response had a reversal of deficits in attention and memory although patients who did not have a sustained virological response didn't see that. That's interferon. What about the new interferon-free drugs? Well, we don't have a lot of data yet, and it'll be very interesting, and we've already speculated about that. What we do have is just very early data, which was presented at EASL this year, and I come back with my last slide to hepatic encephalopathy. These are patients with Child-Pugh A and B liver dysfunction, and after 24 weeks of sofosbuvir and ribavirin, no interferon, we see improvements in these markers of liver function, platelet count, albumin and ALT, but also an improvement in ascites, and they have reported an improvement in overt hepatic encephalopathy. So that's very interesting. The question is, though, whether viral elimination, at least from the peripheral blood, whether that will result in an improvement in the more mild cognitive symptoms which I've discussed. And I think that depends on viral penetrance, or depends on the drug penetrance into the CNS, and also the reversibility of those downstream events in the brain after the virus is gone. And with that look to the future, I'm going to stop.